Good evening. It is 22:15 on the East Coast. My name is Michael Potter. It is the 30th of August, 2020, and as you can see, we'll be doing Case Connection 2 tonight. Currently, I am speaking into a microphone. I do apologize, however, my webcam broke. Hopefully, you can hear the audio. If not, I will re-record this audio for addition to the assignment. So we're moving on. We're going to start with case connection 3. This is a clinical case of a 5-year-old boy brought into his pediatrician's office for his annual visit. He's been a sickly infant and often appears drowsy. He is presenting with persistent thirst and polyuria, frequent urination. The insulin measurement at time 0 and 1 hour after a glucose loading test are as you see on the screen. Simple glucose loading test is an oral glucose solution administered via oral, and a timed test to compare against a control. Ultimately, this patient's likely diagnosis is going to be of a diabetes mellitus type 1. In diabetes mellitus type 1, the beta cells of the islets of Langerhans are not producing sufficient insulin. There are other types of diabetes mellitus type 1 in which the pancreas is producing insulin. However, it's an ineffective form of insulin, usually either malformed or just unable to make correct cellular reactions. Insulin is crucial to regulate many enzymatic reactions within the cell, as well as in the blood. In the presence of hyperglycemia, insulin binds to cellular receptors to increase expression of transporters to the cell surface. These transporters are GLUT4 proteins, and they allow for a lot of glucose to enter and exit the cell. As glucose is a large polar molecule, it is unable to cross that hydrophobic cell membrane. Moving on. This is a visual representation of the effects of insulin binding to a separate receptor site and exerting intercellular effects, which then ultimately create a channel via the GLUT4 protein to bring glucose into the cell. So a normal blood glucose range is 80 to 120, although you will find some reference literature stating that the range is 70 to 130. Anywhere in either of those ranges is usually acceptable, unless you are looking for a diabetes, which in pediatrics is going to be anything over 126 in a fasted state is going to be considered diabetes. They're listing the enzymes. While there are many enzymes that are inhibited by insulin, as well as insulin affecting an excitatory response on many enzymes. We're going to focus on these two right now. Glucose 6 phosphatase, also G6 PACE, is inhibited without regulatory effects of insulin. The G6 PACE will continue to dephosphorylate glucose 6 phosphate into glucose and a free phosphate. Not exactly the opposite of glucokinase or hexokinase, but essentially reversing the process for the glucose into a free glucose again, not creating ATP as the glucokinase and the hexokinase would have used an ATP and into ADP. This is going to create a free phosphate group. Ultimately, this free glucose is going to be allowed to leave the cell via the similar transport system that brought it into the cell, increasing the blood glucose level of the patient. The second enzyme we're going to discuss here is going to be hormone-sensitive lipase. There are a few different forms of the hormone-sensitive lipase. However, in this particular case, we're going to deal with the short form, which is expressed within the adipose tissue. This enzyme hydrolyzes stored triglycerides into free fatty acids. Insulin stops this process and prevents it from happening. However, in the absence of insulin, this hormone-sensitive lipase is going to constantly be hydrolyzing these triglycerides into free fatty acids, which are then released into the blood. This is associated with a syndrome known as diabetic ketoacidosis. This is a very dangerous condition for diabetics, especially seen in diabetic type 1, where while their blood sugar is not significantly high, we usually see this 300 to 400 range, but they are exhibiting altered mental status or even unconscious, but they are in a very dangerous situation and need to direct medical care at this time. Other than that, this is the end of lecture for case study 3. We're going to move on now to case 4. This is the previously healthy 2-month-old female. He's presenting with jittery spells several hours after breastfeeding. She has just recently been able to eat and have a gap of approximately 2 hours between feedings. The mother reports these symptoms started after the baby started entering these fasting states where the child has not eaten immediately within the last hour to 2 hours. Laboratory results are consistent with hypoglycemia. That's a low blood glucose level, but they're otherwise unremarkable. Epinephrine is administered with no increase in blood glucose, but there is an increase in blood lactate. Physical exam reveals the liver edge 4 centimeters below risk classification of essentially hepatomegaly, where the enlarged liver. The blood glucose levels after breastfeeding are good, but the child cannot maintain levels within a normal range in a fasting period. So these are the options, but ultimately we're going to end up determining this is going to be a glycogen storage disease, which is an inability to store or use stored glycogen. There are multiple. We'll talk about that at the end of this lecture. However, we're going to move on to the ones that it is not. So, hereditary fructose intolerance, or HFI, is not likely what this child's experiencing. Her only sustenance is breast milk, and while there can be elevated levels of fructose in breast milk, if that's a predominant and in the mother's diet, the child would have had that presenting earlier if this was the case. Normally, presentation of HFI becomes when the children begin consuming foods containing a high amount of fructose, but the actual individual is with HFI is lacking in adolase B to cleave fructose 1-phosphate into and move it along the chain. This inability to cleave the fructose 1-phosphate ends up leading to seizures after vomiting, which are symptoms that are just not presented in the case study. We move on to the galactosemia. Galactosemia is an inability to metabolize galactose. This inherited disorder is likely caused by one of 3 enzymes, uridyl transferase being the most common, also the most serious. The galactosemia would have presented within the first days of the child's life. A treatment of formula, which is strictly sucrose based, is usually the treatment for these child. They usually have almost no deficits if added quickly, although there are some cases of disorder where they are very injured very quickly. And again, this would present when the child's eaten and in the fed state, as opposed to beginning to show only when she enters the fasted state. Glucose 6-phosphate dehydrogenase deficiency is all. Although it does present with enlarged liver, the issue would be is that the patient's blood work does not show any anemia. Without the anemia, this just cannot be the glucose 6-phosphate dehydrogenase deficiency. This glucose 6-phosphate dehydrogenase is essential in the red blood cells to reduce NADP plus into NADPH. Without this ability, they become very susceptible to oxidative stress. These oxidative stress causes the Heinz bodies to be created, which are a conglomeration of hemoglobin molecules that have been oxidized, and they ultimately lead to premature lysing of the red blood cells, which leads to anemia. Also, it should be noted that this deficiency is almost exclusively seen in males, but even if the odd female is able to have it, the lack of anemia is a rule out for this particular cause. So we move on to what it probably is. This is most likely a glycogen storage disease, and with the hepatomegaly and the increased lactate that is presenting, we can likely say it could be the von Gerk version, which is GSD number 1. However, it's very difficult to determine completely without a full battery of tests. The hypoglycemia in a fasted state is due to the inability to release the glucose from the glycogen stores or the inability to create glycogen stores. This increase in lactate is due to the pyruvate accumulation by and thus not being able to convert lactate into pyruvate within the cytosol. So GSD is inability to score or access previously stored glycogen. It is inherited group of inherited disorders, and again, genetic testing would be required for this child. Also, it would be a good idea to have the parents get tested just for any current siblings of the child or future offspring to determine a treatment plan and to just test early to ensure that we can get ahead of it. So here's the references, and I will include the reference page with in-text citations with my paper, and I thank you for listening. Have a good night.